Hello and welcome. I am Kim Nitz, a Community Program Manager for the Parkinson's Foundation. We are passionate about helping every person with Parkinson's to live better, so it's great to be reaching so many of you today in our virtual meeting format. We have participants from all over the state of Nebraska and the Heartland. Welcome to all, no matter where you're joining from today. Today's program will focus on Parkinson's symptoms that may be experienced a few years into a diagnosis, along with strategies to help manage those. We have two well-known speakers we'll be hearing from today and appreciate the great response we've had from the community to join Julie and Cheri in this program. I want to quickly share a bit about the Parkinson's Foundation for those of you new to us. Parkinson's Foundation is here to support the estimated 1 million Americans living with Parkinson's disease, as well as the many who care for them and those who are working to end the disease. For those of you new to the foundation, we focus on three goals: advancing Parkinson's research, improving care for those living with Parkinson's, and empowering the PD community with educational resources. These resources are extensive and include our website, parkinson.org, our free educational book series that you can download or order in hard copy. I'm going to show you a couple of those. Our library of recorded podcasts and webinars, and our hospital safety kit called the Aware and Care Kit, which Cheri will be talking more about later. A great resource, if you have not connected with them yet, is our national helpline at 1-800-4PD-INFO, which is staffed by Parkinson's specialists ready to assist. On June 12th in Nebraska, we'll be hosting Moving Day Omaha and welcome all of you to get your team registered now. Moving Day is our annual walk event that brings the local community together to celebrate movement, support the Parkinson's community, and raise funds to fight PD. The walk will be held in person on Saturday, June 12th at Stinson Park. However, the event will be adjusted to allow for social distancing and other health and safety precautions, including staggered walk times and socially distanced PD exercises. Teams will also have the option to instead participate online at a virtual Moving Day on Saturday, May 22nd. We know everyone has unique concerns and needs, so we invite you to participate in whichever way makes you feel most comfortable and safe. Also on June 12th, join us in Lincoln's Tower Square for Parkinson's Revolution, an outdoor cycling experience to generate awareness and advance our mission toward a cure. Learn more about that at pdrevolutionne.org. We are proud at Parkinson's Foundation to offer PD Generation, a national research initiative that provides genetic testing for PD-related genes and genetic counseling to people with Parkinson's at no cost in English and Spanish. The goal of PD Gene is to leverage genetics as a powerful tool to help us uncover what is responsible for slowing or stopping the progression of Parkinson's. Learn more and enroll at parkinson.org/PDGeneration or contact our helpline. And before we get started, I want to thank the sponsors of today's program: Acadia, Accorda, Boston Scientific, Kyowa Kirin, and Synovian. Their support helps keep today's program and many others free and available to our Parkinson's community. You can find educational materials about these companies and the resources they offer by visiting our chapter supporter page located at the link you see on your screen and in the chat. And now I'd like to introduce our first featured speaker, Julie Pavelka. Julie is a nurse practitioner in the Department of Neurological Sciences at Nebraska Medicine. Her specialties include memory and movement disorders with specific interest in Parkinson's disease. Julie is extremely active with outreach programs and networking with Parkinson's disease patients, families, and caregivers. Just a note before Julie gets started, we will be sharing a recording and an electronic copy of the slides from today with all of our registrants over email in the next few days. And also a reminder, we ask you to submit any questions you may have via the Q&A icon at the bottom of your screen. And now I'll turn it over to you, Julie.
Thank you very much, Kim, and I'm very happy to be here speaking for the Parkinson's Foundation today. on behalf of Nebraska Medicine and UNMC. Beyond the diagnosis today, managing changing symptoms, Cheri and I are going to be focusing more on symptoms after you've been diagnosed and have experienced symptoms for several years into the disease process. And I want to remind everybody, it's so important that everyone's Parkinson's disease symptoms progress at different rates. Some people, it seems like they progress a little bit more rapidly, and it seems like at 10 years, their symptoms are a lot different than somebody who has had disease 30 years or something like that. But I want you to take each one of your individual symptoms and focus on yourselves, not the general population for this. Who gets Parkinson's? Well, there's a lot of people that get Parkinson's. About 1 million people in the United States get Parkinson's disease every year. There's 10 million worldwide, and there's about 60,000 cases that are new every single year. Parkinson's is so common and occurs so often that it's actually the second most common neurodegenerative disease, secondary to Alzheimer's, which Alzheimer's would be the first most common. It usually affects people over 60. However, if you're under 60, you can also experience what we call young onset Parkinson's disease. And really by definition, less than 50 years old is considered early onset or young onset Parkinson's disease. Parkinson's disease can affect any race. It affects males and females. However, males are affected a little bit more than females. It can be any ethnic group. It doesn't focus really on any particular group. And keep in mind that the young or younger onset, less than 50, it's a very small percentage, around 2 to 10%. So what are the causes of Parkinson's? That's one of the first questions that everyone always asks when they come to their visits, time after time. Do we still know what causes Parkinson's? Well, we wish we did, but the cause of Parkinson's is still unknown. The scientists and the research developers are continuing to work very hard to determine what the actual causes are. And at the best guess that they have from the research that's been completed, it's really a combination of environmental factors, maybe a combination of genetic risk. Parkinson's is really rarely hereditary. In fact, there's a very small amount, about 10 to 15% of all Parkinson's cases are inherited. And like you'd have to have a gene, like a LRRK2, if you've heard of that, or a GBA gene or the alpha-synuclein gene. And you might have that gene and it might put you at greater risk, but you may never develop symptoms for Parkinson's disease. So again, these gene mutations that are related to Parkinson's disease, genetic, they often don't even cause symptoms. So environmental, a lot of studies have showed that occupational exposure to certain chemicals like pesticides or herbicides on farms or different heavy metals, people that have worked in like as welders, solvents. So for example, mechanics who have cleansed their hands and their tools, et cetera, in years in solvents. Even air pollution, they're thinking may have some elevated risk for Parkinson's disease. So a lot of people think it's more of a rural disease, but it also can be, in the city as well. Other risk factors include age. As we age, we talked about the last slide, when we get into our 70s and our 80s, as we have more risk factors for acquiring other diseases. That's the same with Parkinson's disease. Traumatic brain injuries or other stressful events also seem to exacerbate Parkinson's disease. We probably, all have already have the precipitating factors to have it, but then like a sudden death or something very stressful may cause it to happen a little bit more rapid. I've had several patients, they had gone to one of their spouses or a child's funeral or something, and they said, when I was sitting at the funeral, I noted my left pinky was tremoring, and I just thought it was nervous. But that's when they can pinpoint that their symptoms started. What's happening in the brain with Parkinson's disease? Well, it's a lack of dopamine. And the lack of dopamine actually was first discovered really in the 1960s, even though we've had these movement disorder, issues that go clear back to the Parkinson's generation in the 1800s. It really, dopamine itself is really, the lack of it was in the 1960s. What is dopamine? Well, it's a neurotransmitter or a chemical messenger, one of many chemical messengers and transmitters that we have in our brain that actually becomes depleted with Parkinson's disease. And dopamine is so important because our coordination of movements, our cognition, our memory and speech, even our mood is affected by dopamine. So when we have a depletion or a decline of dopamine, hence we start having symptoms of Parkinson's disease. But also, in addition to dopamine depletion, there's also many other chemicals like norepinephrine, acetylcholine, and serotonin that also are deficient with Parkinson's disease, and those are being studied a lot more. I like this picture that you have on your screen, which is the dopamine levels of a normal neuron and of a Parkinson's affected neuron. And you can see on your screen how let me get my pointer here, how on the normal neuron, you have all of this dopamine. There's lots and lots of dopamine, plenty of dopamine, and you have normal movement. Then you go down to the Parkinson's affected neuron and look at that. It's completely depleted, which results in the movement disorders. And it's important to note that oftentimes we have 50% depletion of our dopamine before we ever even start having symptoms, having the motor symptoms of Parkinson's disease. So many, many years before we ever have symptoms, our dopamine is depleting. And that's what the researchers are working really hard on, is how can they slow down or stop the loss of the dopamine producing cells. So that's what they're really focusing on to completely slow down the progression of the disease. What do you need to know about Parkinson's disease symptoms? Well, Parkinson's is a very complicated disease. People think that it just is the motor symptoms, but we have found out through the years that non-motor symptoms are actually just as important and affected as much as motor symptoms. So Parkinson's affects your whole body, including your mood, your thinking. And again, even though we call it a movement disorder because of the tremors or the slowness and stiffness, it still can affect all of our other body systems, which cause the non-motor symptoms. And it's essential to remember that symptoms are diverse. They usually develop very slowly over time. It's usually a very gradual progression of the disease. It's not with idiopathic Parkinson's disease, which is specifically what we're discussing today. It's not a rapid progression. So you don't see a rapid progression in, for example, 2 years of the disease. I saw a patient actually a couple of weeks ago. She had disease. She'd been diagnosed 30 years ago, and she had her walker, and she walked right into my office like she owned the place, and she's doing very well. So always remember, it affects everyone differently. How is Parkinson's diagnosed? Believe it or not, it's very difficult to diagnose because there aren't a lot of conclusive tests. We can't draw blood and say, yep, your dopamine level, it sure is low. You must have Parkinson's disease. So making an accurate diagnosis is very important. And oftentimes your nurse practitioner or your PA, your family practice physician, or maybe even your internal medicine physician, or maybe even a specialist from a different discipline like cardiology or dermatology, notices something that they are concerned about Parkinson's disease, and they will then refer you to a movement disorder specialist who is a neurologist who has additional training, a fellowship actually, in movement disorders. And so they specialize in diagnosing and treating Parkinson's disease. It's very important for your first visit with your movement disorder specialist to obtain a very thorough history of your symptoms. When did your symptoms start? What other medical problems do you have that, might be exacerbating your symptoms, or maybe you're on medications that seem to be making your symptoms worse. It's very important to do a complete neurological exam, as we discussed before, because not only what we can see with our eyes, the motor difficulties with the tremor and the slowness and the stiffness, but also the non-motor features. And we're going to get into the motor and non-motor features at length here in a few minutes. We also use a rating scale, which we're also going to discuss in a few minutes. It's called the Unified Parkinson's Disease Rating Scale. And that is how we evaluate your symptoms over time. So for example, earlier today, I was seeing a patient and I could look back 4 years ago and their scale had only changed by 2 points, which shows us that the disease progression has been very, very minimal. Also with Parkinson's disease, the response that a person with Parkinson's has to their medications, specifically Carbidopa-Levodopa, which is Sinemet, as it works directly on the dopamine receptors, whereas a lot of the other medications work on different receptors, including like what we talked about, the acetylcholine, they might work on the serotonin, in addition to the dopamine. There's also a DAT scan, and the DAT scan was developed, it was actually in 2011, it was approved by the FDA as a diagnostic test for Parkinson's disease. However, the DAT scan is good for differentiating between essential tremor and Parkinson's disease, but it doesn't differentiate between idiopathic Parkinson's disease and other Parkinson's plus syndromes. So we have to be very cautious with interpretation of the DAT scan images, and it's really important to have a neuroradiologist and a movement disorder specialist to understand the interpretation of them. But the scan really measures the activity of the dopamine transporter, which we pointed out earlier. That's what we're depleted on, is the dopamine transporter. And the DAT scan examines more the functioning of our brain compared to like an MRI or a CT scan, which looks at the anatomy of our brain. The motor symptoms, like I said a few minutes ago, we're going to discuss both the motor symptoms and the non-motor symptoms. The motor symptoms are tremor, bradykinesia, and rigidity. Oftentimes the tremor is a resting tremor. So exactly what I talked about earlier, you might have your hand lying comfortably on your lap and you notice your little finger shaking or something like that. And then bradykinesia is slowness. So, it takes you longer to get dressed. It takes you longer to get in and out of bed, etc. And then rigidity is the stiffness. It's essential to remember that bradykinesia, which is the slowness, absolutely must be present with one of the other two symptoms being tremor or rigidity for a diagnosis of Parkinson's disease. So if there is not bradykinesia, you cannot diagnose Parkinson's disease. Another movement symptom a lot of people refer to is the postural instability or difficulties with balance or falls, but this is not an early sign of idiopathic Parkinson's disease. And when I say idiopathic Parkinson's disease, I mean the good old garden variety Parkinson's disease, not the Parkinson's plus syndromes. That's when we usually see more troubles with falling and earlier postural instability. So the motor symptoms, we use a lot of different terms in the clinic and stuff when our patients are at our appointments. And so I really wanted to go over the motor symptoms and the different terms that might be utilized because it's difficult to describe what you're feeling, but you let us worry about the terms and you just tell us exactly how you're feeling. So cramping or dystonia, which is a sustained or repetitive twisting or a tightening of your muscles. And this can affect your neck, as in cervical dystonia. It can affect your arms or your hands, even your legs. It might feel like a Charlie horse, or your feet. If any of you have had toe curling before, that is what dystonia is. Some people with a drooling or sialorrhea, which is excessive salivation. And really, it's not due to producing excess of saliva. It's actually you have a decreased rate of the natural reflexive swallowing. And so everything else is, decreased, as in your blinking and your movements. Well, your swallowing is also decreased. So remembering to swallow frequently is very important. Dyskinesias, which are involuntary and erratic movements. And this can, again, include any part of your body. And we're going to talk about that in depth a little bit later. Festination of gait. So this is when you're taking like stutter steps. You take real short, rapid steps. And most people, if you start festinating with your gait, they think you're going to fall, even though oftentimes you catch yourselves because you're used to it, but it really does scare the people around you. But it's just a stutter step, but it really does increase your risk of falling. And it's often associated with freezing of gait. And freezing of gait really, it describes the difficulty that you have initiating your movement. So it can be just a simple delay when you're starting to walk, or again, you could be with the stuttering or the festination of gait that we talked about. And it really can be triggered when you're backed into a corner, or if you are trying to get into an elevator, or you're trying to get something out of the closet. Anytime you're in a small area or going through a doorway, freezing of gait is more prominent. And again, this puts you at a very high risk for falling. The masked face, or hypomemia, which is oftentimes one of the first symptoms a spouse or a child might notice of their parent, because they all of a sudden have like an appearance of a poker face, and they think that they don't have any emotion, or they might think they're upset or mad, but really it's just a lack of emotion. So that's called hypomemia, and it's a combination of both the rigidity and the bradykinesia. Micrographia, so that's another symptom that seems to get a little bit worse, and we see more as Parkinson's progresses. Your handwriting gets very small, or it might feel cramped to you. The shuffling of gait, which is often the result of a stooped or forward flexion of your posture. And then the hypophonia, or the soft speech. And a lot of times this worsens also with disease, and more the mid-stride is where I consider the talk today. It seems to get a little bit worse, and speech therapy is really important. Let's move on to the non-motor symptoms. And again, these changes usually aren't early in disease. These are more in mid to later stages of disease, but cognitive changes. So often it's more difficulty with attention, or planning, or problem solving, or word finding. So you know exactly what you want to say, but you can't get it out. Also, for example, if your spouse would send you to the store and they told you 4 things to bring home, you might only bring 1 or 2 things home if you don't take a list with you. Constipation, actually, we see constipation early before Parkinson's is ever even diagnosed. So that's a very early symptom, and continues. It's the gift that keeps on giving. It continues to haunt us all the way through Parkinson's disease. The feeling of fullness after eating even small amounts. We seem to get full much easier with Parkinson's, especially mid-stage. The excessive sweating, and oftentimes the excessive sweating related with Parkinson's is when our medications are wearing off, and we're going to talk about fluctuation. Fatigue, and then also the seborrheic dermatitis, which seborrheic dermatitis is just like some dandruff. Some people experience the lightheadedness more mid-stage, where you get orthostatic hypotension, where you can be lying down and then sitting up, and then you stand and you feel dizzy or lightheaded, or you might even fall or pass out. And that's orthostatic hypotension. Loss of sense of your smell or taste. And this honestly can be early, before Parkinson's is even diagnosed. And then the mood disorders. These can be early on too, but we often see exacerbation of them as disease progresses. Sexual problems, including erectile dysfunction. Also hallucinations and delusions. We usually do not see hallucinations and delusions early on in disease, but more in a moderate state of disease and later states of disease. People with Parkinson's start experiencing hallucinations consisting of seeing people or animals that aren't there. And these hallucinations can be a result of the disease itself, or they can be a result of medications that you're on. But most often it's a combination of both, of the Parkinson's disease as well as the medications. And then also delusions, thinking maybe that our spouse is someone else, or our child is someone else. And there are a lot of treatments for these as well. Pain, we often don't see a lot of pain in Parkinson's disease. And if we do, it's related to the dystonia that we talked about a few minutes ago. Sleep disorders, and these can again be throughout disease, but they often oftentimes in mid-stage disease really become more prominent. And it can be excessive daytime sleepiness, it can be vivid dreams, you might have restless leg syndrome. Urinary urgency and urinary frequency and incontinence also can be an issue, but not usually early in disease, more mid-stage. Vision problems, so especially when we're trying to read something close, maybe even some diplopia, which is double vision, and sometimes some weight loss. Let's just briefly go through the stages because I think it's very important for you to understand the stages, but by no means, this is just a reference. So there's no algorithm for the stages of Parkinson's disease. And again, the time frames are completely dependent upon each individual person. But there are 5 stages of Parkinson's disease that we like to refer to. And again, they vary from person to person. But stage 1, a lot of times people don't even know they have Parkinson's disease at this stage. In fact, oftentimes we're not even diagnosed in stage 1. Might be a little bit slower, might have some tremor, but usually we're going about our business. We're still, working or playing golf or doing whatever activities we enjoy. It might be like a little bit of change in your facial expression, which is what we kind of discussed a little bit, or a little bit of tremor that you notice. Stage 2, symptoms are gradually getting a little bit worse. They might be a little bit more noticeable to you. And this might be when you go into your primary care provider and say, hey, I'm not able to get dressed, or it's taking me longer to get this project done. I used to be able to outwalk my husband, and now he is a block ahead of me, or something similar to that. And you're still completely independent in stage 2. You can live alone, but it just takes you longer to get things done than it did previously. In stage 3, this is really considered mid-stage. You might begin to have a little bit of loss of balance and the slower movements. However, as Cheri's going to elaborate on a little bit more, this is when physical therapy is even more important. Of course, it's important at all stages, but this is when it's really important to improve your core strength. And you might have a little bit of a trip or a fall. But again, you continue to be completely independent. You might have some difficulties with dressing and eating and stuff, but I still have patients in stage 3 that are living a very active life and still working. So stage 3, even though your symptoms are most noticeable, you're still able to live a very healthy life. And I really think it's important to point out with all of the stages, the goal is for the quality of your life to be, the best that it can be, and to do whatever we can to make our lives as healthy as we can. Stage 4, our symptoms are a little bit more severe, a little bit more limiting. We might use a walker or a cane, but you can still be at stage 4 and not use an assistive device. A lot of my patients prefer to use the furniture in their houses to an assistive device. But oftentimes in stage 4, you might need a little bit of help getting, washing your back or getting your clothes on and, stuff like that, because it takes you a little bit longer. And oftentimes you need more help at stage 4. So, maybe people coming into the house, or, your kids helping or whatever, but a little bit more help in stage 4. And then stage 5, this would be the last stage. And this is, of course, the most advanced and the debilitated stage of Parkinson's disease. Oftentimes you aren't able to walk or could be bedridden, and you might require around-the-clock nursing care. But oftentimes this is, with our healthy lifestyles, there's many patients with Parkinson's disease that don't even ever get into stage 5. We have some different rating scales that we use at Hohen and Yahr. It's a simple rating scale. It was actually first introduced in 1967. It rates it on a 1 to 5, similar to the scale or to the stages I just showed you, but 1 and 2 is early stage, 2 and 3 is mid stage, and 4 and 5 are more advanced stage Parkinson's. So most of you, if you're mid stage, you're in about the 3 on the Hohen and Yahr, and you can always ask your movement disorder specialist at your appointments, hey, where am I on those rating scales? There's also the UPDRS. This was developed in the 1980s. We talked about it a few minutes ago. I'm not going to deliberate on it, but it's a combination of mentation and behavior and mood, also your motor exam. We also look at your activities of daily life, etc. So every time that you come into the clinic at your movement disorder specialist's clinic, we actually perform a UPDRS to compare how your scores are compared to 3 months ago, 6 months ago, 5 years ago. So if you're ever interested in that, make sure you ask your movement disorder specialist, hey, how's my score today? And of course, 0 is perfect. And the higher your score is, the worse your symptoms are. And 108 would be the highest score. The Movement Disorder Society also updated the scale in, probably 2007, 2008. That is the MDS, Unified Parkinson's Disease Rating Scale. And we also utilize that in our clinic, and research really focuses on that more specialized scale. The theory of the PD progression, which is the Braak's hypothesis. I'm just going to go over these slides quickly because I want to get to some more important information. The current theory of Parkinson's disease is really that the earliest signs of Parkinson's disease are really found in our enteric nervous system, our medulla, and the olfactory bulb, which controls our smell. So under this theory, they think that progresses only over time to the substantia nigra and the cortex of the brain. The theory, is to the non-motor symptoms. So the loss of smell, which is the hyposmia, and the sleep disorders and constipation, they may precede the motor symptom features by years and years and years. I mean, I've had patients that had sense of smell difficulties for 20 years or so before they were ever experiencing any motor symptoms. So that's why the researchers are really, really focused on the non-motor symptoms to decrease or to detect the Parkinson's disease much earlier, because it occurs so much earlier than the motor symptoms. So hopefully we can stop the progression. This is just a Braak hypothesis showing the changes of the brain. And as Kim said earlier, you all will be receiving a copy of the slides, so you'll be able to go over the ones that I'm going through a little quicker. This is the basic model of the dopamine levels, and I think this is a very important slide to show you and to explain to you, because this is how we determine our ons and our offs for Parkinson's disease, and we're going to go into detail on ons and offs. But this blue line here where my cursor is, that's the medication effect, and that represents how we think the level of dopamine in the brain changes after you take your medication. The levels seem to rise up, and then as the dopamine wears off, the level goes down. And then there's the therapeutic window with the white area, and the goal is really to get our dopamine levels right into that therapeutic window so that they're not all over the place, so that you're not wearing on or off, so that you don't have the absence of dopamine. And this dark blue area here, which is under the curve, that's when you get a little bit too much dopamine, and you might have the dyskinesias or the wigglies, and we're going to talk about those a little bit more. And then unfortunately here in this light blue off to your screen, this is when your symptoms are off. So after you take your medications and your body metabolizes them and you don't have any more medication, this is when you're going to experience your wearing off, which we're going to talk about a little bit more. I'm going to go through these slides. This is just before Parkinson's. It shows the black line, how our endogenous or our natural or normal dopamine is just at a steady state all of the time. And then in early Parkinson's, we have the off time maybe before our morning dose. So for example, over here, we haven't taken our medicine since 11 o'clock. We sleep all night, so we haven't had medication for 8 hours. Here we are before breakfast, we're completely off. Then we take our medication and our dopamine level goes off, or excuse me, goes up. Then the natural progression, it starts to go down, goes down, goes down. Then we take our next dose, and it's this kind of on-off effect that we have, kind of roller coaster effect sometimes. And then maybe if we have a late dinner or something here, we can really go off, and we can go off at a much more rapid pace, and therefore our medications need to be adjusted. And I'm just going to, these next ones, this mid-stage one, actually, this is a really important one. So the natural dopamine levels, again, which is this black line, they're well below our therapeutic window. So this white area is where we want our therapeutic window. That's where we need to be in our therapeutic window to be able to walk and to move. So when we have these deep drop-offs, that's when we're in an off state. So again, this can be an early morning off, it can be mid-afternoon, it can be associated with when we forget to take our medications or when our medications just aren't working. And it's really important during this stage to really use an alarm on your medications to keep you on schedule. I'm going to go by the advanced one since we're not talking as much about advanced today. So it's really important to remember that the non-motor and the motor symptoms that we discussed can occur at any time of disease, but motor fluctuation, dyskinesias, and dystonia really seem to be more prominent as we are in mid-stage Parkinson's disease. And the Parkinson's Foundation has an excellent guide on mid-stage Parkinson's disease that I encourage all of you to obtain, as it's kind of my talk all wrapped up into a nice little book. So let's go through motor fluctuations, dyskinesias, and dystonia. So what are motor fluctuations? Well, motor fluctuations are when your ability to move, to get dressed, to eat, they change, and sometimes they're unpredictable. They're called on or off fluctuations. And it's really important that you know when you are on is when you feel the best. That's when your medications are working. And you know, a lot of time I tell my patients, you have to have a good on time before you really know what an on time is. Because if you're hesitant, oh, I don't know if I'm on, I'm not sure if I'm off, then you haven't had a good on time to determine that. When you're on, your medications will be working well. You will feel as normal as you can and be able to complete the tasks that you want. So on time it can vary from 3 hours, it can vary from 6 hours. It just depends upon person to person. But as levodopa begins to lose its effect, which is what we call wearing off, then you can have these periods which the symptoms are way more noticeable and it's more difficult to do your exercises, etc. That's why we always want our patients to do their exercise or any important business that they need to do on their on time. And early on in disease, you don't notice the motor fluctuations as much as you do during mid-disease. That's when you really start to notice fluctuation of symptoms. And that's when you're really able to tell more when you're on or off versus early disease. You don't necessarily know when you're on or off. Usually when you first developing wearing off, it's like a light switch, but it happens very gradually. So it's just kind of a little bit of slope like that previous graph. And then as disease progresses, it can of course become very unpredictable and it can happen very quickly. So over time, your medications might start to begin to wear off, maybe 30 to 60 minutes before your next dose. As Parkinson's progresses, as the symptoms progress and the disease progresses, levodopa stays effective for shorter periods of time also. You might have to take more frequent doses. So for example, maybe in early disease, you only took your cinnamon, your carbidopa-levodopa, 1 tablet 3 times a day or 2 tablets 3 times a day, maybe every 6 hours. But now, in mid-stage disease, maybe you're needing to take it maybe every 3 or 4 hours. For some people, the first sign of an off period is really the return of a tremor or slowness or stiffness. However, some people also have non-motor symptoms when they notice their symptoms wearing off. So they feel really tired, or I had a patient last week say they just can't think. They're a teacher and they know exactly when they need their medication because as they're presenting their lecture, their word fluency isn't as good as it is when they feel on. Some people also have more sweating, or the drooling might be worse. Even people become very anxious if they're wearing off, or maybe some pain like the dystonia that we talked about earlier you could have when you're wearing off. Dyskinesias, these are real involuntary movements. And most of you, I'm sure, have seen Michael J. Fox when he is performing, within the last 5 or 10 years. He oftentimes has the dyskinesias, a lot of times of his head, but it can affect any part of your body, your arms, your torso, and it can actually kind of cause some muscle spasms. So just remember, though, a lot of people think dyskinesias can only affect one part of your body. They can affect your face, your arms, your legs, your torso. Usually the dyskinesias happen at peak dose. So for example, if you have your first dose of medication, let's say Cinemet at 8 o'clock, and your next dose is at 12 o'clock noon, you'd be peak dosing around 9:30 to 10 o'clock. So you might have some peak dose dyskinesias where you're little, what we call wiggly, and then they maybe only last 15, 20 minutes, and then they go away. So that's usually the most common time we see dyskinesias, is between your two doses at the peak dose. And usually patients with Parkinson's disease feel the best when they have dyskinesias. That's their good time. But their spouses or children or their colleagues, it bothers them because they're moving around. But oftentimes patients don't know that they're even having the dyskinesias. So it usually occurs about 2 hours after it's administered, your Parkinson's medication, specifically your Carbidopa-Levodopa. Sometimes instead of the peak dose, though, you might have the dyskinesias just as you're turning on. So, you know, for example, you might take your medication and you've just taken it for 30 minutes and all of a sudden you have your dyskinesias. But then again, you can have them when you turn off. So maybe 30 minutes before your next dose is due. And this is called diphagic dyskinesias. And even though peak dose are a lot more common, diphagic dyskinesias are also very common. Diphagic dyskinesias are really associated with the low doses of levodopa. So oftentimes we need to boost you a little bit quicker versus the peak dose dyskinesias. And it's very unlikely that, in fact, I don't recall seeing a patient where they've had the peak dose and the diphagic. It's usually either or. And I'm sure it is possible much later in disease to have both. But again, they might be bothersome. They might be very mild, or they might be severe. And I've had patients come in and I think that they're going to have dyskinesias off of their chair. However, when I ask them how, are you having any dyskinesias? They're like, nope, I haven't had any dyskinesias, but their dyskinesias are very severe. So that's why it's important for care partners and children to also recognize these symptoms. Dyskinesias can have a really big impact on your daily life, especially if you're, trying to play golf, or you're, trying to brush your teeth or shave or something like that. And also a negative or social emotional impact. So a lot of times going out to eat or something like that, if you have dyskinesias, it's quite obvious to other people that you have Parkinson's disease. Most people with the Parkinson's they prefer definitely to be on versus being off. So, they prefer to have a little bit of dyskinesias rather than being off because they're unable to move. Dystonia is when your muscles continuously contract, causing parts of your body to twist. It can lead to real repetitive movements or abnormal postures. So over on the next picture, on the next slide, I'm going to show you some pictures of some feet that have some dystonia. And it often starts when you try to perform an action. So if you go to brush your teeth, you might have some dystonia in your arm, or if you start walking, your toes start to curl. But it can also be present when you're just sitting or in bed and not doing anything. Here's the picture of dystonia. So on the left side here, you can see the curling of the feet, the curling of the toes, and then just normal feet on the right. But dystonia can be very disabling, especially in the feet, because it really can impact your ability to ambulate and to walk. Dystonia can occur at any time. There's no rhyme or reason oftentimes to dystonia, but in young people with Parkinson's disease, it's often an initial symptom that they have after activity versus tremor, as people in their 60s and 70s often have tremor as their first symptom. Younger people with Parkinson's usually have dystonia first. Again, like dyskinesia, dystonia can occur at your peak dose, or it can occur when you're wearing off. It can be very predictable, and it can also be unpredictable. Most commonly, though, it occurs when the dopamine levels are really low, or if your medications are just starting to kick in. Some people have the dystonia first thing in the morning, or they might have it as their nighttime medications are wearing off before they take that first time dose. Sometimes it can persist throughout the day and not correlate with any timing of your medications. It's very important to have a Parkinson's symptoms diary, and I left the website. Parkinson's Foundation has an amazing worksheet and symptom diary that they utilize, and I have most of my patients do logs, because it really defines on and off times. And really, it's a snapshot of your life from the time you get up until the time you go to bed. And if you get up anytime during the night, I like them over a 2-week period. And we can look at the fluctuation of symptoms and see if it's, you know, on or off symptoms, what's causing the dystonia or the dyskinesias and your fluctuations. And then we can make medication adjustments according to that log. So any kind of log, any kind of notebook that you can have to track your symptoms is very important, even so much as what you've eaten or the exercise you've done. Everything needs to go in this log. So please, when you get your copy of slides, go to this website and take a look at the worksheet. It's absolutely amazing. What do we do for, you know, what's the treatment for the motor fluctuations? Well, there's a lot of different things we can do. We can increase your levodopa. We can increase the amount of tablets that you take with each dose, or we can change the frequency of dose. We could add a COMT inhibitor. Some of you might be on intactopone or tolcapone, as Comtan. Also, this can be with your Carbidopa-Levodopa in a combination medication called Stalevo. We can add a dopamine agonist, which makes the dopamine in your brain and the dopamine that we're giving you with the Cinnamate work better. And this is ropinirole or pramipexole or rotigotine. The other names would be Requip and Mirapex and Nupro for that. We can add an MAOB inhibitor, which would be selegiline or rasagiline, that can make the other medications that you're on work better and work longer. We could switch your immediate release Carbidopa-Levodopa to an extended release, or even a combination preparation, which is called Rytari, works very well. It's 1/3 immediate release and 2/3 long-acting release Carbidopa-Levodopa. And, you know, oftentimes the theory now is that we use a combination of medications to treat your symptoms versus maximizing each medication before we add another one. It's much more beneficial for our patients for quality of life to use a combination of 2 or 3 or even 4 medications to manage the motor fluctuations. Also, apomorphine, or also called Apokyn. It's a FDA approved. It's a short-acting dopamine agonist, and it can be used for rescue therapy. And it's very similar to like an EpiPen or insulin injection, and it works very rapidly. So if you're suddenly off, you can't move, you do the injection, and within 3.5 to 12.5 minutes in the studies, you had benefit of symptoms. There's also Kinmobi, which it's a sublingual form of dopamine, and it's absorbed under your tongue, like a strip, like a Listerine strip or something similar to that. And it also takes effect very, very quickly for your off times or motor fluctuations. There's also a powder aerosol inhaled formulation of levodopa, and that's Inbrija. And again, these medications, the Inbrija, Kinmobi, and apomorphine, they're all, you know, related to the dopamine and dopamine agonist of medications. So they're just a new formulation. It's the dopamine that's been around forever, but it's just a new formulation that allows us to divert our off symptom or our off states much more rapidly. Management of peak dose dyskinesias, we can give smaller, you know, decreases in levodopa. So maybe we'll, you know, you're taking 3 tablets with each dose. Maybe we'll do 2.5 tablets and then give it more often instead of 3 tablets with each dose. Sometimes we have to remove other medications. So the medications that we just talked about that we add for motor fluctuations, sometimes those actually can cause peak dose dyskinesia. So we might have to change the timing of those or even decrease them. There's also amantadine that works very well for dyskinesias. And there's also extended release amantadine, which is just taken once daily, that can improve the dyskinesias. Morning dystonia, sometimes we have to add a bedtime dose of a controlled release. The Rytari works well, or the Carbidopa-Levodopa ER. Also, sometimes patients, when they get up in the middle of the night, I actually have them take, you know, a lot of patients do get up during the middle of the night to go to the bathroom or something. I just have them have their medication there on their bedside stand, and they take it. The diphasic ones, sometimes we have to increase doses or maybe smaller doses, you know, every couple of hours might help the diphasic dyskinesias. And then there's also Botox, the Botox injections that really help the overactive muscles for the dystonia. Additionally, deep brain stimulation. So after, medications, you're having a lot of fluctuations, the quality of your life might not be, what you desire. We can proceed with deep brain stimulation. And it's an evaluation that determines if you're a candidate for the deep brain stimulator. And this goes into a place in your brain, usually the subthalamic nucleus. There are a couple other locations that we can put the deep brain stimulator, but it provides electricity stimulation to your brain, to the movement center. And that's what helps regulate the abnormal brain cell activity. And by providing electricity is very beneficial for tremor, bradykinesia, which is the slowness, and also rigidity. So the deep brain stimulator can be very, very beneficial for resolving dyskinesias, for significantly improving your fluctuation of symptoms, and also dystonia. It can be very beneficial for. And also, if the Duopa, which is the Carbidopa-Levodopa intestinal gel, is a formulation that allows a continuous dopamine, which is the cinnamon that you get, with continuous dopamine, levodopa, into your small intestine. And the difficulties with taking oral medications is we take them in our mouth, then they go down our esophagus into our stomach, and they can get hung up in our stomach because of food or protein. As the Carbidopa-Levodopa and protein, they fight for binding for the same receptors in your gut. So it takes that Carbidopa-Levodopa to get down into your small intestine to where it's really can be absorbed, and then has to get up to your brain. So the Duopa pump is awesome because it completely diverts your stomach, as the tube goes directly into your jejunum, or into your small intestine. So it's very similar to what diabetics have for a pump or a pain pump. It's recommended that the pump is on about 16 hours per day, which people will usually put the pump on when they get up in the morning, and then they remove it when they go to bed. And sometimes they'll take an oral dose of medication to get them through the night, and then start all over during the day. So when you're on the Duopa pump, other than taking nighttime medications, you do not require any other oral medications. The biggest determining factor with a Duopa pump is really lifestyle factors really must be taken into account when you're choosing this therapy, on how active you are. And, you have to, if you're very active and you're playing tennis all of the time, or you like to, run marathons, et cetera, it might not be ideal because it can get dislodged. And at this present time, with the size of the pump, you do have to wear it with a vest or a little like fanny pack type of bag to keep it safe. So every situation needs to be evaluated very closely. And the same company who has developed Duopa is working on a subcutaneous pump that is actually going to be very beneficial as well. And also will have a pump. It'll be much smaller, and it will be very easy to use. All right, I think we're going on to Cheri.
Yeah, thank you, Julie. And I know that we will all look forward to being able to go back and review the slides. Just a reminder to everyone, lots of great content. You can go back and watch the recording, review the slides, and just keep learning. So I am thrilled to introduce our Heartland Advisory Board member, Cheri Prince. She has a doctorate in physical therapy and is director at PDWELL in Omaha. Her clinical interests are in the treatment of Parkinson's disease, and she holds certifications in LSVT-BIG, as well as Parkinson's wellness recovery. She offers a number of community resources through PDWELL, and she'll be sharing some of those during her presentation. So I'm going to turn it over to you, Cheri.
All right. Thank you so much, Kim, and thank you all for being here. I'm so excited to visit with you for just a little bit of time today. I would love if we were all together, but of course we can't be right now. So I'm very grateful for Parkinson's Foundation for asking me to speak. And I would really love to be doing it in the same room as Julie, as we love speaking together and just plain hanging out and being together, but we can't do that today. So we're doing our best to present virtually on a topic that is near and dear to both of our hearts. So first thing I want to do is just get a wellness. We're not going to do a long wellness break because our talk isn't very long, but I want you to take a minute brain break before we start again. So if you're sitting and it's easy for you to stand up, I want you to stand up. Otherwise, I want you to sit in your chair with really good posture. We're going to take 3 big breaths, and we're going to reach for that ceiling as much as we can. And we're just gonna, you can do some voicing if you'd like. You can count it out nice and loud and get your voice moving since you've been quiet for a while. But we're just gonna go ahead and take it up. So let's do 1, nice and loud, and come back down. And 2, nice and loud, and come back down. And 3, nice and loud, and come back down. Stretch as much as you can. Shake yourself out a little bit. Move those shoulders, that neck, and have a seat so we can finish out our talk. So Julie presented so much great information about the medical management, just the medical details of beyond the diagnosis. So what it looks like a few years down the road after you've been diagnosed, and just the medical management. But I am going to talk a little bit today about a couple of things. Non-medical management, so what you need to do besides medication to manage your symptoms, both motor and non-motor. And also, as we progress with Parkinson's, as well as we age, we sometimes end up in the hospital for various reasons. And so I'm going to talk a lot today, or a little bit today, about hospital safety. It's a topic that is also near and dear to my heart because I've seen things go wrong when someone with Parkinson's goes to the hospital. And so I'm going to give you a little information about that. And I keep forgetting that I need to advance my slides. So sorry. Okay. So non-motor or non-medical management of changing symptoms. How do we do this? So today I'm going to propose that the best way that we do that is by building a care team. So building a whole team around you of people that can help you manage your Parkinson's disease. And when should you do this? I would say that you should start now if you haven't, or upon diagnosis. So if you're already at that beyond diagnosis stage, time is now to start it. If you've just been diagnosed, it's a good time to start it as well. Why do you need a care team if you have a doctor? And what I really should have put on here is, why would you need a care team if you have Julie, right? Nobody needs anybody else but Julie, but that's kind of teasing, yes, but we know she's awesome, but we do need other people as well. And so we're going to talk a little bit today about who you want to have on your team, how important it is for you to self-advocate for yourself, both with your physicians and with your other care team members. You are the person that knows your symptoms the best, and so you need to be your best self-advocate. There's a concept of a board of directors that I kind of came upon through a friend and colleague of mine who had actually heard about it from a patient of hers. And the concept was this was from a care partner that said, he believed, his wife had Parkinson's disease. He believed that all persons with Parkinson's should have a board of directors. And this board of directors would be people that you ask to be on your board. You choose them to help you manage Parkinson's disease. And they would need to be people you trust, people you feel comfortable with, and feel comfortable with you. Because sometimes we have to, if we're a person with Parkinson's, we have to hear things that we may not be aware of ourselves. And so you have to have somebody that you feel comfortable with, and someone that feels comfortable speaking directly to you. Also, somebody that you have easy access to, that you can get advice at, kind of a moment's notice or just in a short period of time. I love that concept of the board of directors. So you can call it a board of directors, you can call it a care team, you can call it your posse. I don't know what you want to call it, but anything you want to call it, your support system that you have in this battle and journey with Parkinson's disease. Different members on your team are going to do different things for you in managing, and we're going to talk about that. So these are some members of your team. And the only thing I want to mention, Julie didn't talk too much about this, but I find this as a therapist that people ask me frequently, I was diagnosed by my primary care doctor. Do I need to see a movement disorder specialist? Do I need to see a neurologist? And I always tell my patients, yes, you need to see a movement disorder specialist. You may not always see them if you live far away from one. You may not see them for every appointment, but as a consult, as a member of your care team, they're invaluable. All that medication information that Julie just gave, you're going to get the best information related to Parkinson's from a movement disorder specialist. So on your care team, you may have a neurologist and you may have a movement disorder specialists, and you're for sure going to want to have a primary care physician. You've got to have somebody else coordinating your other medical conditions, because even if you have Parkinson's, you can't forget about some of the other things that need to be taken care of. We're going to talk about all of these briefly. So we'll go on to our next slide. So the first thing we're going to talk about is one of my favorite topics, which is exercise. And this is how much exercise you should maybe get. We're going to go into more detail, but the current recommendations are at least a prescription for 150 minutes of exercise per week at least, with your heart rate elevated, that's causing you some work, so you're sweating and you're enough to feel fatigued. So that's just kind of a little cute prescription. First thing we're going to talk about is exercise. Exercise is medicine. So this is the first kind of topic besides support that we're going to talk about in managing non-medical management of your progressing symptoms. So physical therapy, occupational therapy, and speech therapy. We're going to talk about those first. Physical therapy, when do you need it? So again, as well as with building your care team, I would tell you it's upon diagnosis or now if you have not seen a physical therapist that specializes in Parkinson's disease. I do believe that everybody that's diagnosed should see one so they can have an established exercise program. We know that exercise is one of the few ways that we can potentially stall the symptoms and progression of Parkinson's disease. And so the sooner you can get that established, the better off you are. We think you should check in approximately every 6 months to make sure your adjustments and your program is current for the symptoms that you're having. Who should you see? So I really recommend that you see a physical therapist that has expertise in Parkinson's disease. They might be certified in LSVT, which many of you have heard of that, the LSVT BIG program, or POWER, which is Parkinson's Wellness Recovered, but some sort of advanced knowledge of Parkinson's disease if you have that available to you in your area. And then how do you get it? We want to talk about this difference between therapy and community wellness. Therapy you can get paid for under Medicare and your insurance. You do have to have a prescription from your physician. So again, that's where that care team comes in, right? The physician writes the prescription, you see the physical therapist for the treatment. What will you get when you go to physical therapy? These are the things that are really important related to Parkinson's disease. Amplitude-based treatment. As Julie mentioned before, we have less dopamine, so therefore that changes how our body moves. We have less amplitude. Many of you know that if you have Parkinson's disease, that it really wants to make you small, right? Small steps, soft voice, small movements. So we need to treat with amplitude or big movements. And so that's the background of LSVT BIG, of course, more complicated than that, but that sums it up. So amplitude-based treatment should be included in your physical therapy. Flexibility to battle the rigidity of Parkinson's disease. Of course, balance, strengthening. I think Julie referred to core strengthening, how important that is for your posture. Again, to battle that forward flexed posture that Parkinson's wants to give us. We have to work on strengthening our core and postural re-education. One of the things that Parkinson's also does is it impairs our ability to really know how our body is moving in space. And so we have to do some kind of re-education on where your body is and how to increase the self-awareness of how your body's moving. Certainly gait training or walking is very important in Parkinson's disease, working on those big steps. You may have freezing or shuffling. All of those things can be addressed by a Parkinson's-specific physical therapist. Reciprocal patterns. One of the first things we kind of lose in Parkinson's disease is that ability to reciprocally move our extremities. And so we want to work on that when we go to physical therapy. And then dual task training. So dual task training is the idea of working your brain and your body at the same time. Research in Parkinson's disease and exercise right now shows that that is really how you get the best carryover and the best improvement of your symptoms is when you challenge those systems at the same time. So you challenge your brain and your body at the same time, and that creates better neuroplastic pathways in your brain and better brain change. We're going to talk a little bit more about that in a little bit. And probably one of my favorite things that you get when you go see a therapist, probably more than what you want, is education on what kind of exercise you should be continuing to do throughout your journey with Parkinson's. So occupational therapy, what's the difference? Occupational therapy, you're going to get some more ADL training. If you're already definitely, if you're kind of at that beyond the diagnosis stage or that mid stage of Parkinson's, you're probably having some difficulties with ADLs or getting dressed. ADLs are activities of daily living, getting dressed, doing your grooming and hygiene, taking a bath, going to the toilet, all of those things. So you'll get some of that if you work with an occupational therapist. Fine motor, many people's first or primary complaint is their handwriting and difficulty being able to write anymore and have it be legible. So working on fine motor skills, buttons, tying shoes, all of those fine motor things. Functional mobility, so getting around your house, getting around your kitchen, being able to do your what we call IADLs or instrumental ADLs, working on laundry, cooking, all those things that we have to do. And then occupational therapy can also address cognition. Speech therapy, speech therapy, when do you need that? So this is another thing, you'll see that this is kind of a repeated slide, but as a therapist that works in the realm of Parkinson's disease, I would tell you that you need speech therapy upon diagnosis or now if you have not had a speech therapy evaluation. Definitely, we want to establish the same patterns with speech therapy as we do with physical therapy, in that you need to move your voice and move those muscles, strengthen them just like you do your arms or your legs or your core. And so the sooner you can get started on voicing exercises, the better off you're going to be and establish those lifelong patterns. Again, recommending that you check in every 6 months for adjustments. Who should you see? Definitely, again, a speech therapist that has a background in Parkinson's disease. There are several really good speech therapy programs for Parkinson's disease. One is LSVT Loud, many of you have heard of that, or Speak Out. So looking for therapists in those that have those certifications that have some background for you, that will help. What will you get when you go to speech therapy? So the three kind of areas related to Parkinson's disease are that speech and voicing. So frequently with Parkinson's, we see that soft voice, slurred, mumbled speech, rapid speech. So a little bit like that festinating gait, right? Where we get started, we start strong and then we kind of get going and we can't stop, but our voice trails off. Facial masking and word finding, all of those things can be a difficulty with Parkinson's, and that's what your speech therapist will work with you on. Cognition, so that slowness, so bradyphrenia, slowness of thinking. So just like we have bradykinesia or the slowness of movement, we definitely can get slowness of thinking. So that's something that speech therapy will work on. Impaired memory, attention, executive function. And I had a patient the other day talk to me about how she just couldn't solve problems anymore. And she wasn't talking about math problems. She was talking about things that she was trying to do in her daily life, like how to cook something in the microwave. She couldn't remember the steps that she needed to take, or she was having more trouble remembering those. And so speech therapy will address those things. Also swallowing, drooling management of secretions, difficulty swallowing pills or food or coughing or throat clearing, that hoarse voice, all of those things would be addressed by speech therapy. This is just a little joke that I think I actually originally got from Kim. So how much exercise would you say you skip each week? We don't want to skip our exercise ever, right? We want to complete it for sure. Okay, so when we get done with our therapy, what do? We know we have to really continue to exercise. And I really put this on the therapist, to be honest with you. I tell most of my patients, hopefully I remember to tell all of them when I evaluate them, that the idea is that one of my goals for therapy is to find an exercise program that you're going to stick with that's going to address your symptoms during the course of your therapy, so that when therapy is done, you're not done doing exercise. You've just found a more maintenance type way to do it. So these are what I kind of call name brand Parkinson's specific community-based wellness programs. So Delay the Disease, many of you have heard of these. Delay the Disease, Rock Steady Boxing, Dance for Parkinson's, Yoga, Tai Chi, Loud Crowd, Live It Up, so many things. But what I wanted to mention on this talk today is that even if you live in an area where you don't have these, unfortunately or fortunately, I guess, one of the silver linings of the pandemic is so many things have become available online or virtually. So everybody, almost everybody, would have access to any of these programs, even if it's online. So if you live in an area where you don't have any sort of community exercise, we could help you get connected with a virtual option. The other thing is, if you don't have any of these in your area and maybe virtual is not for you, but you have a YMCA, I'm going to tell you some things you want to look for in an exercise program in order to meet what you need for Parkinson's disease, okay? So Parkinson's therapy and or wellness program, these are the things we should include. Anti-gravity extension, so working against that flexion that we have. Rotation, weight shifting, transitional movements, so that's transfers, stepping, working against freezing, alternating movements, we talked about that. Dual tasking, working your mind and body together, and voicing. So any class you went to that had these kind of as options would be a great class for Parkinson's disease, even if it's not called Delay the Disease or Rock Steady Boxing. And then these are the other things I want you to think about when you're looking for an exercise class. How you exercise is very important, okay? There's going to be 4 things we're going to talk about here. High physical effort, working harder than you think you can, harder than you want to maybe, forced intensity. So the research shows that when we work harder than we think we can, that's when we see the biggest improvement in Parkinson's disease, okay? Emotional engagement. We want whatever you're doing to be fun, which is why we have that whole list of Parkinson's type exercise, right? Not everybody loves boxing, not everybody loves dance, but hopefully you can find a program and maybe it's a couple of different things you do each week to keep it yourself engaged, making it fun for you and rewarding. Nobody's going to keep doing anything that's not fun. So you have to find a class or a group or a way at home to make your exercise fun. Attentional focus. You have to be thinking about how your body's moving to get the maximum benefit in Parkinson's disease, attending to how you're doing. And then cognitive engagement. So having it be a complex movement. And so not only thinking about how your body's moving, but also having to think about the actual exercise, having it be complex enough that you have to use your brain during it. Those are the things we want to look for. All right, that was exercise 101, really fast. So we're going to keep going here. The next thing on non-medical management of your symptoms is support, and connection is key. I always say exercise is my favorite, but then when I talk about connection, then that's my favorite. So it's really hard to say, right? Connection is so important, getting plugged into your Parkinson's community. My first recommendation is that you find a support group that fits you. There are a lot of different Parkinson's support groups out there. There are educational ones where you just learn every month. There's nothing wrong with that. That's a great format. I used to facilitate one just like that. It's a great format, and that might be the perfect fit for you. You just want to learn everything you can. Maybe you're looking for more support or sharing or discussion. You want to be able to talk about how you're feeling. There are support groups out there that fit more in that line. Sometimes there's combinations. Maybe they do a couple of educational events a year and a couple more support and sharing. There are specialty support groups. Julie facilitates 2 of these, women with PD and a care partner. I also facilitate another care partner group. So there's lots of different kind of specialty ones. Many people feel like their Parkinson's disease wellness classes, so those community wellness classes that we talked about, are their support system. And that can be great. Working out people that are going through the same thing as you can be very supportive and very connecting. There are other things you can do that are outside of maybe what you think traditionally related to Parkinson's, like a book club. Our PDWELL hosts a book that the book isn't about Parkinson's disease, but I shouldn't say we, I would love to join it, but I don't facilitate it, but the participants read the book, have a discussion. It works on voicing, it works on cognition, but it's also a support group of types. Singing, whatever you're into. Also other recreational activities that you can do with other people that have Parkinson's disease. I know several people that get together to play ping pong or pickleball. So activities that benefit your Parkinson's disease symptoms, but also promote a sense of support and community while you're doing that. Again, another silver lining to COVID is there's so many virtual options now. I think my contact information and Julie's probably goes out when you get the slides for this. So if you don't know how to find virtual options in your area, reach out to me. I'd be happy to help you. Also, there's Parkinson's Nebraska that has many resources on their website that you can find out about support groups and other things. Okay, so back to the other members of the team. We're only going to talk about these as a bullet point because we don't have time. But these are other people you might want to consider bringing onto that care team, right? Onto that board of directors. So dietitian or nutritionist, again, we could have a whole talk on how nutrition can benefit you in the mid stages, well, in all stages of Parkinson's, but certainly at this beyond the diagnosis time. Mental health providers and spiritual advisors can definitely help you manage your support system, help be another section of your support system besides your support groups. Massage, acupuncture. I know several people with Parkinson's that feel like those two complementary therapies have helped their rigidity very much. So that's something to think about. An eye doctor or neuro-ophthalmologist, dentist, and dermatologist. Those are other healthcare providers that you should consider, whether they have a background in Parkinson's disease. That would be very beneficial, but at least telling your dentist and your eye doctor that you have Parkinson's disease so that they're aware and you can have an open communication about those things that might be changing. And then some people further down the line end up needing to invite a palliative care provider onto their care team. Okay, we're not going to have a lot of time to talk about hospital safety, but we are going to talk a little bit about hospital safety. So sometimes as we, like I mentioned before, as we age or as our Parkinson's progresses, we end up going to the hospital, and it's very important that we are able to do so safely. So this is just some numbers from the Parkinson's Foundation that out of people that have Parkinson's disease, persons with Parkinson's disease, 1 in 3 will get hospitalized. So out of 3 people that have Parkinson's disease at the hospital, 1 will get admitted. 3 out of 4 of that group of people, right? So out of 33 hospital visits of this first 100 patients, 3 out of 4 or 25 will have their medications changed, and they may not be aware of it during the course of their admission or their stay at their hospital. And then 2 out of 3 of those, so 16 out of the original 100, will have complications from that, which those are pretty staggering numbers when you think about it. Hospitals are safe, right? That's what we all think. And hospitals are great places. But there are some assumptions that we go into going to the hospital with that are not necessarily true. We think they'll call our neurologist. We think that the pharmacy will for sure have your formulation of Parkinson's medications. We think that all medical staff understand Parkinson's disease, that they know that that you taking your Parkinson's disease medication on time is very important. And they know that there are some drugs that are unsafe for people with Parkinson's disease. The truth is that people with Parkinson's are hospitalized 44% more than their peers without Parkinson's disease, and people with Parkinson's suffer avoidable complications at a higher rate than non-Parkinson's patients. This yields longer hospital stays than people without Parkinson's disease. We're going to kind of go, there's a lot of reasons why this happens, and I will tell you that there is a whole presentation on this program from Parkinson's Foundation called Aware and Care. And if this is something that you're interested in, I can get you more information about that program. So we're not going to go into the details of why it happens within the hospital systems, but we are going to talk to you about what you should do. And this is where the Aware and Care program comes in. So Parkinson's Foundation's Aware and Care campaign can help everyone be better informed. Both persons with Parkinson's, the care partner and their family, healthcare providers, and hospital and facility staff. This kit helps patients and families plan for hospital stays and advocate for the best possible care while you're there. This is what a kit looks like. I actually have one here too. So it looks like this little bag. It's actually provided free from the Parkinson's Foundation. I'm going to tell you how you get one in a minute. And inside it has all of these things. It has things that you need when you go to the hospital, fact sheet for nurses that you can give to medical staff that tells them some information about your symptoms, how to manage your symptoms, what medications you should not have, and how important it is that you have your medications on time. It also comes with this little magnet that says that you can put like on your whiteboard in the hospital or on the frame of your bed if it's metal that says, I have Parkinson's disease and I need my medications on time every time. This just kind of goes through what's in the kit. It also talks about a hospital action plan, about how preparing for a hospital visit. So again, this gets back to just being better prepared, self-advocating, advocating for yourself in the case that you may be hospitalized in the future. When should you use this kit? For a planned or emergency hospital stay. So bring it with you if you go to the hospital or go to the ER. I usually recommend you take it to your annual checkup with your Parkinson's doctor because it's a good time to make sure they know about the kit. Julie and the staff at Nebraska Medicine know about the kit, but not every physician does. And so you can educate them as well about the importance of hospital safety in Parkinson's disease. Traveling, taking it with you when you travel in case something happens while you're out and about. My husband just broke his leg when he was out of town in Rapid City. Now, he didn't have to be hospitalized and he doesn't have Parkinson's disease, but these things happen when you're out and about. And so something like that could happen to you. So take it with you when you travel. And then extreme weather emergencies. I know we have people from all over the country, but I think that's mostly talking about like hurricanes, things like that. If you get separated from your house, take that kit with you. Have that be one of those things that you take with you. So this talks about how to get a kit. You can get one at parkinsons.org, or you can call the helpline, which I know they've already mentioned and we'll probably be mentioning more, but the helpline, Parkinson's Foundation helpline, you can order one there as well. Oh dear, sorry, I'm going to stop my sharing for a second. All right, Kim, I think I think I blew past my last slide. So I'm not gonna share my slide, but I'm gonna give you these bullet points, okay? So I was on a presentation the other day and a person with Parkinson's, so I can't steal this from them, but I loved this list. He said, what I've learned is this: you have to find the right neurologist, find the right treatment, advocate for yourself, exercise every day, find your group and community, be prepared, and find your purpose. And I thought that was the perfect list for this talk as well. So those are the things, checklists of what you need to do. So thank you for your time.
Love those. And thank you, Cheri. Lots of great information. We do have time for a bit of Q&A, and I want to remind everyone, we can't see you, so make yourselves comfortable. Get a sip of water, and we're just going to take a few questions here. I'm going to start with Julie. Is it important to space meds out and not eat before and after my Carbidopa-Levodopa?
Yes, so that is, everybody's different on that. So again, it goes to the dose, the fluctuations of your symptoms. So eating, unfortunately, slows the metabolism down of your medications. So if your medications aren't working as well for you, it's best to take them on an empty stomach if you can. But some people, if they become nauseated or something, we like them to take them with a little bit of food, but maybe some crackers or something that's not necessarily high protein, so that they metabolize a little bit better. So the thing with Carbidopa-Levodopa, and that's why your logs are so important, because it varies so much. I have patients that take it at 6 a.m., noon, and 6 p.m., and that's fine. They do absolutely wonderful. I have other patients who take it every 3 hours. So it just depends when you're wearing off, when your symptoms are bothersome, when they're impeding the quality of your life versus when you feel on, when you feel good, when you feel like you can perform everything, that you want to. So it really varies from person to person. There's no set rule. If you were to look up Carbidopa-Levodopa in a book, it would say the maximum dose is, 600 milligrams or something. Well, we know we use, a lot more than that. I mean, I've used, 2,600 milligrams before. So it's just variable. And that's why that symptom log and worksheet are very important.
Excellent. Another for Julie, you talked about how constipation just becomes a fact of life. If the normal methods, trying fiber, hydration, exercise, are not working, what do you recommend? Is it a laxative?
Yeah, so usually Miralax works the best for constipation related to Parkinson's disease, and it's very safer because it's very safe because it's more of a fiber medication versus like a laxative or a stimulant. Also, prune juice works very well, believe it or not. 8 ounces of prune juice every morning with your breakfast. I know that sounds delicious. Also works well, but Miralax long-term has not shown any side effects or negative impacts.
Okay. Then for Cheri, how to mitigate pain and cramping in legs and arms?
Right. So a lot of that is that rigidity. And that's why I think it's so important for you to see a physical therapist first, because sometimes what happens is we start an exercise program and we kind of exacerbate things and then we stop totally. And then our symptoms of cramping or soreness or all those things can get worse. So the best thing really is stretching and flexibility. I know a lot of people advocate for intense exercise, and I even said that forced intensity exercise, but that shouldn't be your whole program. A lot of your program needs to be flexibility. And as you work on flexibility, you will find that you will have decreased cramping and decreased rigidity.
Okay. Julie, we have a lot of questions about how to get expert care for Parkinson's. One person saying, they live 5 hours away, Western Nebraska. Can you use telehealth for Parkinson's visits?
Absolutely. That's a great question. So, in Nebraska, the University of Nebraska Medical Center is the only, movement disorder center as far as having the comprehensive movement disorder clinic. And ideally, if we can at least see you for your initial visit in our multidisciplinary, our comprehensive Parkinson's clinic, which is an evaluation by the movement disorder specialist, the speech therapist, occupational therapist, physical therapist, of course. Cheri was giving me the eye there. Just thought I was going to forget him. And then if we can do telehealth maybe every 6 months, and then like a yearly visit to the clinic, it really works the best. We can do so much over telehealth, even every 3 months over telehealth. Also with electronic medical records now, it's so much easier to communicate with questions, et cetera. So really, an annual visit with a movement disorder specialist, the rest we can do pretty much telehealth and via one chart.
Okay, great. And, just to build on that, somebody asking, how do they find a doctor specialized in Parkinson's? Call our national helpline, especially if you live beyond the borders of what, we're kind of talking about today. Our helpline maintains a list of movement disorder specialists and other expert care teams. So
absolutely. And I mean, there are Iowa, Kansas, Colorado. I mean, there are movement disorder specialists. That helpline, they have so many resources. So please utilize it.
Then we have a question for Cheri about aware and care. I've never heard this and I like it. Does an ambulance crew maintain a checklist to ask if a patient has Parkinson's?
Boy, I do not know the answer to that. I don't think so. I would be surprised if they do. In the aware and care kit, there is a wallet card though, because I know most EMTs, if you're not able to answer questions, they look for medical things in your wallet. And there is a wallet card in the aware and care kit that says, I have Parkinson's disease, gives your emergency contact information. So that's another piece of the aware and care kit that would maybe help you in that instance. That's part of the aware and care program, really trying to find all these different avenues of getting the word out. So I think EMTs would be a great one as well.
Yeah, I'm going to take that one back to our team. That's a good one.
It's a good one.
A question for Julie again on meds. Is it common to have a different reaction to the same medication made by a different manufacturer?
Absolutely. Unfortunately, so there's not a million, I'm exaggerating, but there's 100 different generic medications of Carbidopa-Levodopa. In fact, I have a patient that at one pharmacy, they get a round pill. It's still a yellow for their Cinnamate 25/100. Their other pharmacy has an oval pill. And manufacturers, some people do not respond to one medication over the other. So I know they're supposed to be the same, but if you have a manufacturing and the manufacturer is on your prescription bottle that works for you and another one doesn't, you can request your pharmacy, because it's still generic. It's still going to be in your generic copay. You can request them to order that for you.
Okay, great. We had a question, Cheri, about Julie mentioned using furniture for walking assistance, how that's sometimes a go-to. What is a real guideline from a PT standpoint about when an assistive device may be needed?
Right, so that's a very dicey topic in Parkinson's disease, because sometimes our assistive devices can actually exacerbate some of our Parkinson's symptoms. So they can actually cause us to freeze more because our brain's kind of seeing that as a barrier, like it would maybe a door frame. And many therapists, including myself, before I learned more about Parkinson's disease, the first time you see a patient being unstable, what do? We give them a walker and say, here you go, now you're going to be safe. And so that's where that assessment by a therapist that really does have some experience with Parkinson's disease comes in, because we have to try a lot of different things. And many people, some people might be on right now that I've seen recently, where we try several things. We try walking poles, we try an upright walker, we try a rollator walker, we try a U-step, and just see what's better. Certainly if we're falling and having unsafe, we don't want to get hurt. We don't want people falling. So if we need stability, we have to find something that will give that stability, but we have to find the right one. So that's where I really feel like you really need to try and seek out somebody that does have a little bit of Parkinson's background, so that they can really fish out, is your walking worse with the walker because you're freezing or because of balance? You know, all of those kind of issues that are involved.
Okay, that's great advice. And then just based on time, I'm going to go to our last question. We talked a lot about connections, Cheri did. As far as connecting with an area support group, I know that we've got a majority of attendees today that are from that Lincoln and surrounding area. And I did want to give a shout out to the Lincoln Parkinson's Disease Support Group. Rich and Joyce Starr have asked us to welcome anyone looking for a group that's meeting virtually. They're going to continue to meet virtually. So really encourage you all to check them out if you're in the area. We'll include them as well in our follow-up documents, so you'll have their contact information. And with that, I'm going to just do a couple of wrap-up slides. I first really want to thank Julie and Cheri for sharing all of their expertise today. We appreciate your time. And it's a good point to say, the attendee feedback, all of you who are here today, it's vital to us to share your feedback so that we can shape future programs. So if you'll stay on for a moment to complete a short survey, it also will come out in the follow-up email to you. But please do share any thoughts that you have about today's program. We recognize there are questions we didn't get to. We do always encourage you, ask those of your healthcare provider. Julie talked about, get those written down, take them to your provider, or you can call our Parkinson's Foundation helpline. We want to give another thank you to our sponsors, Acadia Accorda, Boston Scientific, Kiowa Kirin, and Synovian. And don't forget to visit them there on the web page. And then for those of you ready to stay engaged in the community, there's a lot of other good programs coming up virtually. Next week on April 7th, we're going to kind of step back and do a Parkinson's 101, what you and your family should know. So for those just getting familiar with Parkinson's, don't forget on June 12th, we've got Moving Day Omaha and Parkinson's Revolution in Lincoln. And then our weekly PD Health at Home programs. These are great if you're looking for a way to a lot of variety each week. Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. You can register at parkinson.org/PD Health. We've got some Wednesdays coming up with cognition and brain games. So we thank the Light of Day Foundation who makes those programs possible. And then lastly, the timing is great to let you know that Thursday of this week is the start of Parkinson's Awareness Month. This is a great way for you all to advocate. We have a lot of resources that you can use, whether it's on social media or with your family or your community. There's also a quiz that you can go out that's kind of fun to test your PD knowledge and make you eligible to win some prizes. So check that out. Remember, starting on Thursday, Parkinson's Awareness Month. This does conclude our program today. Thanks again to everyone for joining us. Thank you again to our great speakers. We hope to see you at a new program soon, and please take care.